Good evening and welcome. My name is John Griffin, and I'm the Senior Director for Professional Education and Training for Gynesonics. We're going to be having our participants join us from the virtual waiting room. So we'll just give it a few seconds here, and then we'll begin our program this evening. Thank you again for being here. Okay, I think we have everyone from our virtual waiting room with us this evening. So I'm going to go ahead and begin. Again, good evening. My name is John Griffin. I'm the Senior Director for Professional Education and Training for Gynesonics. I want to welcome you to our Sonata Insights webinar titled The Sonata Procedure for Uterine Fibroids, a discussion on patient selection, fertility, and pregnancy with our faculty, Dr. Leslie Hansen-Lindner, Dr. Taraneh Shirazian, and our own Dr. David Toub, Senior VP of Medical Affairs. First off, the faculty and presenters, thank you all for hosting with me and presenting your insights and experience with us for the webinar. We're glad you're here this evening. Thank you. So I'm going to go ahead and turn it over to Dr. Toub to begin our discussion in just a minute. But I wanted to, first of all, thank all of you for joining us this evening. We have approximately 70 that have registered. I know some will be coming in a little bit later, but we have a good group with us, about 40, 45 at this point. And we know, of course, everyone's had a full day. So we're grateful that you've joined us this evening. We know you'll find this interactive discussion with our faculty very valuable for your practice and overall Sonata procedure knowledge. So a couple of reminders. First off, please join us in making this an interactive session. We welcome your participation, your comments in the chat. Any questions that you have, feel free to either ask by raising your hand using the chat function on your screen, or you can use that chat function to type a question, or again, raise your hand with the hand emoji that you see there in the middle of our screen, and we'll go ahead and unmute you. And so, without any further ado, I'd like to introduce our faculty for this evening's program. First off, Dr. Leslie Hansen-Lindner practices in Charlotte, North Carolina at Atrium Health and is currently the chief of the Department of OBGYN at Carolinas Medical Center. She received her MD in training at the University of Pennsylvania and has practiced at Atrium for over 25 years. She is a clinical adjunct professor at Wake Forest University and is active in medical student education. Dr. Hansen-Lindner's clinical interests focus on advancing minimally invasive and hysteroscopic procedures for the management of AUB and fibroids. Dr. Hansen-Lindner is co-author of the Journal of Clinical Medicine article, Transcervical Fibroid Ablation, an update on pregnancy outcomes. Our other faculty this evening, Dr. Taraneh Shirazian. Dr. Shirazian serves as the director of the Center for Fibroid Care, the Division of Global and Community Women's Health, and Global Women's Health at NYU Global Institute of Public Health, and is an associate professor in the Department of Obstetrics and Gynecology at NYU Grossman School of Medicine. She's board certified and completed her residency at Mount Sinai Medical Center, earning her MD from Brown University. Specializing in managing benign gynecologic conditions, Dr. Shirazian is dedicated to improving patient quality of life through personalized treatment plans and innovative technologies. She is also a passionate advocate for global women's health, serving as president and medical director of Saving Mothers, a nonprofit she founded. Dr. Shirazian is a recognized voice in national media and editor-in-chief of Around the Globe for Women's Health, a practical guide for the healthcare provider. And finally, Dr. David Toub is Senior Vice President, Medical Affairs at Gynesonics. He received his AB and MD degrees from the University of Chicago. He completed a fellowship in pelvic surgery at Graduate Hospital under Harry Reich and Francis Hutchins, Jr. He also served as an attending physician at Pennsylvania Hospital, where he held faculty appointments at both Thomas Jefferson and the University of Pennsylvania. He's a fellow of the American College of Obstetricians and Gynecologists, a diplomat of the American Board of Obstetrics and Gynecology, and an associate member of the Royal College of Obstetricians and Gynecologists. A laparoscopic and pelvic surgeon with a special interest in providing alternatives to hysterectomy, Dr. Toub has been a faculty member and speaker at various conferences and has authored several chapters in many books in gynecology. So we are very fortunate to have all of you with us this evening. Again, thank you for sharing your time with us and your insights and perspective. And so with that, I'd like to turn it over to Dr. Toub to begin our discussion. Dr. Toub.
Thank you, John, and greetings, everyone. It is a pleasure to be here with my colleagues, Dr. Hansen-Lindner and Dr. Shirazian, to talk with you about fibroids in pregnancy and a focus on transcervical fibroid ablation with the Sonata system. Next slide, please, John. So I just want to talk a little bit about fibroids and infertility. So do fibroids cause infertility and or spontaneous abortion or miscarriage? The general opinion, speaking with a lot of gynecologists out there, and I think how most of us have been trained, is that fibroids that indent or butt the endometrial cavity, namely FIGO types 1, 2, 3, and transmural fibroids, which are 2-5, and maybe some intramural fibroids could cause infertility and miscarriage. While the evidence for type 3 fibroids tends to be strongest in the literature for assisted reproductive technology and maybe not as robust for natural conception, those fibroids likely interfere with blastocyst implantation, and that's the general consensus among gynecologists. And cavity distorting fibroids cause first trimester miscarriage. Next slide, please. So what's the evidence? The evidence, as I think most of us know, is that there really isn't a lot of it, unfortunately. Nothing much has been established. If you look at the American Society of Reproductive Medicine's guidelines, they literally state that there is insufficient evidence to conclude that fibroids cause infertility, regardless of whether or not someone is being administered assisted reproductive technology. There's insufficient evidence to determine that a specific fibroid size, number, or location is associated with a lower likelihood of achieving pregnancy or associated with an increased risk of early pregnancy loss. On the other hand, there's fair evidence that hysteroscopic myomectomy for submucous fibroids improves clinical pregnancy rates, and there's insufficient evidence to conclude that hysteroscopic myomectomy reduces the probability of early pregnancy loss in women with infertility and a submucous fibroid. Furthermore, there was a really nice systematic review 7 years ago, along with a meta-analysis emanating from Vanderbilt University, and I quote from them, leiomyoma presence was not associated with increased risk of spontaneous abortion. This involved more than 20,000 pregnant women among all these studies. And where did we get this belief that fibroids cause first trimester spontaneous abortion? Probably because some of the earlier studies didn't adjust for confounders, and they do agree that this is a common clinical belief. Next slide, please, John. Next slide, thank you. So how do fibroids possibly cause infertility, if they do at all? Lots of interesting theories out there. This was from a very nice paper just last year, in fact, from some colleagues in the Netherlands, including Judith Hearn, who was an early user of the Sonata system. And most of these really amount to effects on implantation, also sexual dysfunction, because obviously that, if you don't have intercourse due to dyspareunia, et cetera, you're not going to get pregnant. I think that's intuitive. But a lot of these really revolve around, do fibroids maybe have a negative impact on the local environment for blastocyst implantation? And it's something we really don't yet know for sure. Next slide, please. So let's talk about transcervical fibroid ablation, TFA, and pregnancy. So if you look at the labeling for the Sonata system from the FDA or from CE in Europe, it says that only one thing, the safety and effectiveness regarding fertility and fecundity has not been established, and the potential risks and benefits remain unknown. That's it. There are no warnings in our labeling. It also notes that as something that conserves the uterus as an alternative to hysterectomy, TFA does not eliminate the possibility of pregnancy, nor is a fertility desire a contraindication to treatment with the Sonata system. In fact, we've had normal pregnancy outcomes reported in the literature after TFA, and there was a case series from 2021, mostly in Europe, that basically involved 36 pregnancies, miscarriage rate similar to that of the background rate in the obstetric population, no uterine ruptures, no abnormal placentation, and no increase in postpartum hemorrhage rates. Next slide, please. I also call attention to the fact that many years ago, we used to get a lot of questions about, does TFA cause intrauterine adhesiogenesis? And some people in Europe did their own second look hysteroscopies every now and then, and they didn't find any adhesions, but we wanted to study this as a company. So we did study it. We did a trial called the OPEN trial, and it's one of the only studies I know of adhesions, whether in the peritoneal cavity or in the endometrial cavity, where the investigators were not scoring adhesions. Independent reviewers who had nothing to do with the study otherwise were scoring adhesions. At the end of the day, we had 34 pairs of evaluable baseline and second look hysteroscopy videos, and those are reviewed by the third-party independent reviewers rather. No adhesions were found. That's great. I come from a pretty academic background, as do most of you, and I would look at this and say, that's nice, but this wasn't a powered study, in all honesty. Maybe had we treated 100 women in the study, we would have found an adhesion along the way. And I think that that's reasonable. But I do want to point out this study included 6 women who had opposing fibroids that were very close to one another, usually on the opposite walls from one another. In the literature, that's associated with a 78% risk of intrauterine adhesiogenesis if you do hysteroscopic myomectomy on those fibroids. Those 6 women who were treated with Sonata didn't develop adhesions either. So while we can't prove a negative, the risk of adhesiogenesis after treatment with Sonata appears to be very small. That was the conclusion of the authors of the paper from that study. Next slide, please. So on the left, you see the paper from 2021. It was essentially a European-based paper because that's where we had the most experience at the time. But you see on the right, the paper that Dr. Hansen-Lindner mentioned before, or actually John mentioned when he introduced Dr. Hansen-Lindner. This is the most recent paper outlining the pregnancy outcomes after treatment with the Sonata system. And if you just advance to the next slide, I'd like to get into this in more detail. How did we do this? This was not a formal study. It was not a registry. Essentially, this was a database that was based in part on several studies we did do where we actually excluded women who wanted to get pregnant. It happens. Some people do get pregnant even when they don't intend to. So we did have a couple of patients who were in clinical trials, but the majority of patients were treated on a post-market basis from commercial usage in Europe, including the United Kingdom, Mexico, and here in the United States. All women who did report pregnancies to their treating physicians and who then reported these pregnancies to me or another member at Gynesonics, obviously we got the data with their patient's permission to go in the database. Next slide, please. So this is the data that was published, and it's pretty current. 72 women have gotten pregnant at least once after treatment with Sonata. The mean age was just over 37 years. Over 60%, however, were in the range of 36 to 40 years. The mean gravidity was 2.5. So most women on average were certainly pregnant at least 2.5 times. But I do call out that 26 women were nullogravidi. They'd never been pregnant, and 46 women were actually nulliparous. They'd either never gotten pregnant or never had a vaginal delivery or a C-section. 12 women were enrolled in those clinical trials. 60 women were treated post-market. The average fibroid diameter was just over 3 centimeters. The maximum was 8.4 centimeters, and the most commonly ablated fibroid type by far were transmural fibroids. Those were actually almost 31% of the fibroids that were treated in our database. The next most common was type 3 fibroids at just under 21%. So fibroids that were clearly most likely impactful upon the cavity and probably impactful upon pregnancy were the most common fibroids that we saw in these patients who were treated with Sonata. Next slide, please. So here are the outcomes. 89 pregnancies have resulted so far among those 72 women, and that led to 55 deliveries. 8 women got pregnant more than once after treatment with Sonata. 11 women conceived after assisted reproductive technology. 10 pregnancies are ongoing. 1 patient was lost to follow-up but did deliver. We just do not know the route. The treating physician in Leicester, England, was very diligent, but this patient was delivered at a outside hospital, and he could not get the data. So among the outcomes, we have had 19 vaginal deliveries, 35 sections, all but 6 of which were primary sections, all for the usual obstetrical indications. And as we'll mention in a second, most of them were for patient request, because in Germany in particular, they do that. We had 5 TABs, 18 first trimester spontaneous abortions, and 10 of those 18 occurred among 2 patients. One had 4 miscarriages after treatment. One patient had 6 miscarriages. That patient with 6 miscarriages had a previous miscarriage associated with a submucous fibroid. She was treated with Sonata. She went on to have 4 miscarriages, then had a term delivery complicated by HELP syndrome, but all went well. She ended up with a stat section, got pregnant again 2 more times with 2 more miscarriages, but then had another term delivery. This one was also complicated by pregnancy-induced hypertension, but that was a vaginal delivery. The other patient with multiple pregnancy losses was a very unfortunate patient in London who came into the picture having previously had 16 miscarriages. No evaluation was done, unfortunately, so we don't know what the etiology of her recurrent pregnancy loss was, but she then went on, unfortunately, to have 4 more miscarriages. Even with those 2 patients in there, who clearly were somewhat outliers, as the patient with the 6 miscarriages actually had antiphospholipid syndrome, which we all know is associated with recurrent pregnancy loss, as well as pregnancy-induced hypertension. Even with those 2 patients in there, the overall miscarriage rate was just over 22%. And if you were to remove those pregnancies, the miscarriage rate would then be about 12%. The only pregnancy-related complications we saw were things we see in everyday obstetrics, gestational diabetes, PROM, failure to progress, postpartum hemorrhage, etc. But very importantly, there were no uterine ruptures, no instances of placenta accreta spectrum, and no stillbirths. Next slide, please. This is just the details of the C-sections. Again, 29 were primary sections, but you can see almost 32% of the sections overall, most of which were primary sections, were done at patient request. And about 17% were done for failure to progress, and 17% were done not because of a prior Sonata procedure, but because of a prior hysterectomy in terms of prior sections and or prior myomectomies. Next slide, please. So in conclusion, I do want to point out this is the largest series to date of pregnancy outcomes for any hyperthermic ablation modality, including focused ultrasound. The next highest was a series of 54 patients reported by Heimovichy and colleagues many years ago for magnetic resonance guided focused ultrasound. So this is very significant as a database. This shows that normal term pregnancy outcomes can be achieved after TFA with Sonata. But I do want to point out this is a limited data set. This was not a registry. This is not the absolute 100% population out there of pregnancies. There could be pregnancies out there with great outcomes we do not know about. There could be pregnancies with not so great outcomes we do not know about. So this limitation really needs to be considered by physicians and their patients when contemplating TFA as a potential treatment option in women who may desire fertility in the future. Next slide, please. One thing I do want to point out just before we finish up is that one advantage of the Sonata system is we do have an ablation zone. We do have a complete ablation guide with a safety border, but very importantly, there's this red ablation zone, and physicians can choose whether or not to try to tailor that ablation zone to remain inside the pseudocapsule of the fibroid if they want to avoid adjacent anatomy. So there is that. As far as timing of pregnancy, we've not formally studied this. The earliest documented pregnancy that I could measure was about 3.1 months after treatment when I wheeled it out. We don't know what the appropriate routes of delivery is. We don't know if women who have had assisted reproductive technology can conceive earlier. We do know that fibroid volume reduction, most of it takes place within the first 3 months, and generally speaking, you're going to want a normal cavity before implanting an embryo. So it seems like at least 3 months would probably be prudent. For natural conception, we really do not know. Again, we've had some pregnancies where conception was about a little over 3 months after treatment, but the numbers are just too small to say anything meaningful. So we really don't know what the potential risks are. Next slide, please. These are just some references. Next slide. This is our intended use statement. And again, this only says the one thing, that safety and effectiveness regarding fertility has not been established, and this doesn't preclude the possibility of pregnancy. Next slide, please. And that's all I have. So to toss this over to Dr. Hansen-Lindner, I would like to ask her, as a colleague, what convinced you that treatment with Sonata may be appropriate in some of your patients who desire pregnancy, and what questions do they have for you, and how do you approach that with your patients?
Thanks, David. Thanks so much for the overview. It was a definite evolution, I would say, in my appreciation for what the technology was doing, and then sort of requests from patients, but also some affirmation from a reproductive endocrinologist that I work a lot with, Brad Hurst, who was instrumental in some of the early development of radiofrequency ablation, and his support toward radiofrequency ablation and subsequent pregnancies. So I think it was a number of different factors that helped me to feel more comfortable with patients that were coming to me who had future pregnancy interests. I know that in the first maybe 15 or 20 patients that I ever saw for consultation for Sonata, if they mentioned that they wanted to have a future pregnancy, I did tell them, this is not a procedure that I think we can do for you. But as time went on, as I did more and more, as we had more turn up in the literature, I began to get more and more comfortable with sharing that with patients.
And before we go on, Dr. Shirazian, did you have any thoughts, any comments on that same question that Dr. Toub posed to Dr. Hansen-Lindner?
Yes, thank you. I actually do. I think, when I first started using the technology and when I was thinking about who it would best serve, I wanted to kind of reassure myself as I was using a new technology about that fertility question. So, and we may get to this a bit later, but I routinely do hysteroscopy for all the patients who are trying to get pregnant when I use Sonata. And typically I will use it first. I will first place, the hysteroscope into the endometrial cavity. I will assess the cavity. And then if it's a fibroid that either impinges on the cavity or sort of compressing the cavity from the myometrium, I know more clearly where it's located. And that I found very reassuring. Another very reassuring feature is that you can actually place saline in the endometrial cavity through the Sonata. And again, that provides more reassurance about where all of your existing fibroids are, so you can take even more care to attempt to avoid the endometrium. So when I was first starting and I was really, doing these on a population that was very mixed, some of which may want to get pregnant in the future or have current pregnancy desires, I found that ability to really assess the endometrium, very reassuring.
Thank you, Dr. Shirazian. Well, Dr. Hansen-Lindner, let's go ahead and we'll begin with material that you've prepared for us this evening.
Thanks, John. I thought that one of the ways that we could help all of our clinicians understand a little bit better about why we've seen this progression of understanding and seeing pregnancies progress safely in the numbers that we've had is to see some of the visuals of what happens to the fibroids and to the uterus as these fibroids undergo treatment. As David said, we have a red ablation zone and a green ablation safety border. And that is really nicely outlined by these pictures where you can see that a uterine fibroid, these are two different uteruses, two different fibroids, but they were treated, and you can see the precision of how the fibroid ablation was able to be done, sparing the surrounding myometrium and treating just the fibroid. These pictures were taken 2 weeks after the procedure, so you can really appreciate the necrosis that occurs in the tissue. Next slide. I wanted to show this slide and a subsequent slide to show you from an ultrasound perspective what a pre-treated fibroid looks like 3 months later. And you can see the fibroid is indenting the endometrium, distorting it. This patient had very heavy periods and also had an interest in future pregnancy, and then was treated with the Sonata fibroid ablation. And then, John, the next slide, please. And you can see the significant decrease in the fibroid. And you can also appreciate the endometrium. It's no longer being distorted by the fibroid. So, from the standpoint of pregnancy, we certainly still have the jury out on how much this would actually assist in a patient getting pregnant, but this patient's symptoms were dramatically improved with a significant reduction in the fibroid size and less contact with the endometrium, providing a significant improvement in her heavy bleeding. Next slide, please. This is just another example looking at MRI. Again, the longitudinal process of pre-treatment, post-treatment by 3 months and then 12 months, where the fibroid has significant reduction, and you can barely see it at the 12-month mark. Now this is, I'm showing you obviously some extremely good results. There are fibroids that don't respond as well. You typically have anywhere from 50 to 60% reduction in size, but that range can vary. Obviously, there can be anywhere from 30 to 90%, even a little bit more than that and less than that. But that's a general idea of what you can expect to see of these type 2 to 5, type 3 to 5 fibroids.
Dr. Hansen, we had a question come in on the chat, and I believe it had to do with these 2 slides as you were going through your presentation. The question was, what was the healing process like for that patient?
So the healing process, I'll give a kind of a spectrum because it's different for every patient. Some patients most patients have very little pain, just some mild cramping, and the typical expectations that you would have after a hysteroscopy with some watery bleeding, et cetera. There's a certain percentage, maybe approximately 10 to 15%, who have a fair amount of leukorrhea after the procedure during the reabsorption process. For some people, they just don't have that much. Others have more, but it generally is about 10 to 12% of patients will get a fair amount of leukorrhea for a few months.
And Dr. Shirazian, any other outcomes with your patients? Are they seeing, again, a similar healing process?
Yes, I would say so. I think healing and post-op recovery is, one of the good results, one of the many good results of Sonata. Really, you can go back to work next day. Most patients don't have any significant amount of pain. And I would agree with the 3 months time frame, to really start to see some results.
Thank you. Okay, I'm gonna move to I think we're here, right, Dr. Hansen-Lindner?
Yes, and this is just a little bit of a reiteration of some of what David said. This particular article was one, since it was published in 2021, that started to give me more certainty that we could offer this in women who wanted to have a future pregnancy after seeing the number of women and the reasonable outcomes with no increased risk of the things that you might think would occur, such as growth restriction, morbid adherent placenta, postpartum hemorrhage, et cetera. This gave me a little more certainty that it was a reasonable procedure to start offering to women who desired a future pregnancy. Next slide. In this article in the Journal of Clinical Medicine, and again, David expounded on that in a lot more detail than I'll talk about, but 55 total pregnancies, 35 C-sections, 19 vaginal deliveries. And I'll talk a little bit about how I counsel my patients. And I'd love to hear Dr. Shirazian's input on that as well. But we have increasing data, and I think we're actually over 105 pregnancies now. So the numbers are starting to increase and come in as we've had more than 8,500 cases done worldwide for Sonata. Next slide. So from the standpoint of counseling, the things that I really try to consider as I counsel patients, there was another early study that looked at myometrial integrity, myometrial thickness after radiofrequency thermal ablation of fibroids, and it showed no visible disruption in the myometrial integrity. And that was, again, another point of encouragement, just like the open trial, which showed no adhesions. Small data set, but nonetheless, a data set number that you would expect to see some abnormalities. The same thing with myometrial thickness. There does not appear to be any disruption of the myometrium from a structural appearance. The transcervical route is incision-free, so because of that, there's no increased risk of intraperitoneal scarring. And the risk of intrauterine scarring is quite small. And the preliminary data on multiple opposing fibroids, and I've done a fair number of repeat hysteroscopies in my own patients who have had opposing fibroids, and that adhesion risk remains very essentially non-existent for my patients as well. There has been some emerging data that is comparing RF energy and comparing it to myomectomy, because we really have to compare how we would be treating these fibroids of the sort of gold standard modality, which is myomectomy. And some of this emerging data has looked very similar as far as risk would be concerned in women with myomectomy without the operative morbidity that we see with myomectomy. Next slide. So the documentation that I generally put in my records and also how I discuss with the patients is I talk about the risks of infection and bleeding, hemorrhage, ongoing bleeding or non-resolution of patients' bleeding, suboptimal result, further growth of fibroids, as well as ongoing risk of hysterectomy and death, infection, et cetera. I mean, all of these risks are ones that we give for all of our surgeries, and I really don't change that for Sonata. I also do write in my patient notes that we don't have an indication that details the safety and effectiveness with regarding future fertility. So, and I have the patient verbalize that back to me so that they have a verbalized assessment and knowledge of what we're undertaking just so that they are partnering with me in moving forward with this procedure that is newer for women desiring fertility. And then the question of C-section versus vaginal delivery. I will show this in my last slide, as we've had 7 pregnancies in our group from the 8 physicians that are doing Sonata. And our first patient had actually had a previous laparoscopic radiofrequency ablation about 6 years prior to having a Sonata radiofrequency ablation. And I actually counseled her to have a C-section, but she delivered at a hospital about 3 hours away and had a vaginal delivery and had a, really remarkable primiparous vaginal delivery, not a terribly long second stage. And I don't know if I would say that I think she got lucky or if it really is safe, but there's certainly, as we have more and more women who opt for vaginal delivery, we can have hopefully continued safety data. Next slide.
Excellent. Great. I will absolutely go. And I just want to invite our audience and those with us this evening, if you have any questions or comments, or maybe some of your own experience you'd like to share either in the chat or by using the hand emoji to raise your hand, and then we'll make sure we unmute you. Please feel free to do so.
So in our practice experience, we have had 7 pregnancies. The first I already mentioned, she conceived with assisted reproductive technology, IVF. So this was something that we have, like I mentioned before, we've had a lot of support from our REIs, encouraging patients to consider Sonata as an option as opposed to a myomectomy. Our second patient that delivered had history of a previous myomectomy with significant intrauterine adhesions. And this had happened probably 5 years before her Sonata procedure. And with Sonata, we treated additional fibroids. She had had a previous miscarriage and conceived successfully, and we did a primary C-section at 37 weeks. Third pregnancy, previous C-section, and she opted for a repeat C-section, and that was done at term. She had had a 6-centimeter transmural type 2 to 5 fibroid that was approximately 6.5 centimeters and had a really remarkable reduction in size, and then carried her pregnancy with no complications. We had another patient who had had 6 previous hysteroscopic fibroid resections. She had adenomyosis. She had 3 previous losses, and really wanted to try Sonata just as one more possibility to see if that could assist her. And she conceived and had an early miscarriage. And then I actually have a C-section on Thursday of another patient who had a myomectomy and Sonata. And then we have had 1 other miscarriage and then 1 other patient that's due in August. So we've had a good spectrum, about 28% miscarriages. Both of those patients were over 35, 1 with several previous miscarriages. So a very good overview of what we've experienced so far in our institution. Next slide. Any questions from anybody in the audience? And I also want to invite Dr. Shirazian to share a little bit more about her patients who have been pregnant after Sonata fibroid ablation.
And while we're doing that too, we're going to go ahead and launch our poll with some questions that hopefully will come through. We'll get some audience response on those questions that we have for this evening. But yes, Dr. Toub or certainly Dr. Shirazian, any other comments?
I guess aside from the pregnancy question specifically, I think that one really great group to consider the Sonata procedure in are patients who, you really don't think would be great for a repeat surgery, or who have smaller fibroids that you really would not want to operate on because they're small and So to do that type of myometrial, damage and kind of extensive dissection might not be worth it. Just thinking about pregnancy specifically, obviously we want to maintain the myometrium as well as we can for the patient. And so I think Sonata offers distinct advantage over myomectomy in many scenarios. So I would just invite people to think about that potentially as an alternative. Extensive adenomyosis is also one of those alternative type categories where we don't have great surgical management, but clearly we want to do something to help with symptom control and potentially help decrease inflammation at the level of the uterus.
Thanks, Dr. Shirazian. It's interesting, your comments almost were ahead of a question I was going to ask, so maybe I'll ask it also to Dr. Hansen-Lindner. I'm glad you commented on it. And the question was more around, what you might say, Dr. Hansen-Lindner, to those physicians on the webinar this evening that maybe had considered Sonata more of a niche procedure or something that had more narrow application for a small number of patients in their practice. How might you address that, or how would you respond to that?
So I would say, like any newer procedure, you sort of have a narrower view of what you think it might be able to be used for. And then over time, you can better understand the spectrum of how it can be used. And I think I've come to sort of an assessment of how I view most patients who come to see me for a Sonata consult, because a lot of them come to see me for Sonata and they're actually not great candidates for Sonata. Either their fibroids are pedunculated, or they have multiple large 10-centimeter fibroids, but they've been advised to have different surgical procedures and they're coming for an answer. And that's not the way all of them are, but I've looked at patients and sort of classified them as great Sonata candidates, pretty good Sonata candidates, not great, but I could do it Sonata candidates, and there's no way I could do the procedure. And so I've been able to talk to patients about that and sort of get a better sense for what their goals are, and to offer it to patients who maybe absolutely do not want an abdominal procedure, but they want some improvement of their cycles. And that opens up a framework from offering it to a lot more patients. So it becomes less of a niche procedure and much more having a general application.
Thank you. Dr. Shirazian, did you have a comment?
Yeah, well, I just noticed in the chat that someone was asking about treatment more as like a prophylactic tool in order to reduce kind of potentially future growth of fibroids. And I do think that that is another category. When we see patients who have very small fibroids, smaller kind of intramural fibroids, again, that you really don't want to operate on, but the patient is there in your office saying, well, I don't want to just monitor this 3-centimeter fibroid, Dr. Shirazian, it's going to grow in the next 5 years or 10 years. And why am I just going to watch it? Like, that sort of doesn't make any sense, right? So we know that the growth potential of fibroids will continue in the reproductive years. So especially in a younger patient who's 25, who's 30, who has several, let's say, smaller fibroids, we know that those fibroids will grow. So I do think that one potential application is treating those smaller fibroids, even in patients who are not very symptomatic, because you know that they will continue to grow and they will become problematic at sort of a larger size. So that's a lot of what we do at our center, at the Center for Fibroid Care, because we longitudinally follow our patients. So many do want to intervene early on to try and reduce potential growth and try and address their symptoms earlier so that they don't wind up needing larger surgeries.
Thanks, Dr. Shirazian. Dr. Toub, any other comments? I want to make sure we get to you if you had any others.
Yeah, so I know someone in the chat asked a really, I mean, all these questions are really great questions, but someone asked a question that I really want to go through quickly live about, what about ablating adenomyosis? And it's an excellent question. If you, again, full disclosure, if you look at our instructions for use, this is not within our indication, mainly because the effectiveness is not proven. And the truth of the matter is, I was part of a systematic review with some colleagues in Switzerland at the universities of Bern and Freiburg, where we looked at radiofrequency ablation of adenomyosis, as a systematic review. And all the studies out there, none of which are with devices called Sonata. There are only 7 good studies out there looking at treatment of adenomyosis, either localized or extensive, sometimes adenomyomata, with radiofrequency energy. The 2 best studies I know of, frankly, are from Ninghai in China. There was a really nice series of 72 patients followed up through 12 months with a single needle electrode placed transcervically, not Sonata, and about an 18% reintervention rate at 1 year. Not bad, but they did another study, a 3-year study involving, I think, 85 patients, if I remember. And through the 3 years, they only had a 1.5% reintervention rate when I calculated it. What's the difference? They ended up doing their usual single needle RF ablation, but they added a Mirena afterwards. And they, through 3 years, they significantly reduced their reintervention rate. The problem is everyone uses a different definition imaging-wise for adenomyosis. Even histopathologically, there's not always a uniform standard for the diagnosis of adeno. The terminology is confusing. It's not always standardized. So it's very hard to really compare all these studies. The history of Sonata to date in the literature for adenomyosis is very thin. There are 2 case reports. One was a really nice case report of a single patient followed through 6 months at an academic institution in California. They did all the right things, but it's obviously an N of 1 and a limited follow-up. And there was another case report from some of my friends in Bern of a patient with extensive adenomyosis treated with Sonata. At 11 months, very oddly, some of that adenomyosis actually got extruded into the endometrial cavity and they resected it hysteroscopically. I've never heard of that happening before. And finally, there was a case series of 13 patients in Cologne by Oven Piriev and Tomas Rumer. Of the 13 patients treated with Sonata, 1 was completely lost to follow-up. 3 patients were followed through 3 months, and 9 patients were followed through 6 months. The results were really good, but again, limited follow-up. There is going to be a study in Switzerland looking at Sonata for adenomyosis, focal adenomyosis, 12-month follow-up, looking at pain relief as the primary endpoint, but all the other usual metrics. But that has not been completed yet. So it's still a very open-ended question.
Okay, thank you, Dr. Toub. And I want to thank Dr. Garduno, Dr. Lin, Dr. Freeman, and Dr. Shantz-Dunn. I think there's a few others who have put questions out in the chat. I'm going to get to them in just a second. As a matter of fact, I will get to one of them and ask Dr. Shirazian and Dr. Hansen-Lindner maybe to share their experience. And then we're going to go to a polling question of our audience here in just a second. So Casey, stand by. Any experience with recent GnRH treatment? I don't know if you saw that one, Dr. Shirazian.
Yes.
First, and then I'll ask Dr. Hansen-Lindner to comment. Go ahead.
Sure. Yeah, I love combinational therapies. I'm a big proponent. I think sometimes it's very difficult to completely manage bleeding. And so I think combining therapies can offer the individual patient a lot more benefits. So for example, if I have someone who has a larger fibroid, we're actually doing a study currently looking at the combination of Relagolix or Elagolix plus Sonata in fibroids larger than 7 centimeters to see if the addition of the GnRH antagonist will actually help shrink the fibroid further than just radiofrequency alone. So I think it's a great way to address symptomatic fibroids, especially if they're bleeding. And especially because in the first 3 months post-Sonata, you may have bleeding irregularities as sort of the fibroid is shrinking, as we've already discussed. So the addition of a GnRH agonist has the ability to slightly maybe reduce the volume of the fibroid. And the theory anyway in this study that we're currently trying to do is that potentially that might benefit shrinkage further with the use of RFA. Now, that having been said, I think it's difficult, at least for me, to get women to continue with the GnRH antagonists. I do think there's resistance to staying on a medication, at least in New York City, at least where we practice. But I think for short intervals of time, it could be used pre-procedural and slightly post-procedure to kind of help with outcomes. And then Dr. Toub brought up the use of the IUD. I also just wanted to put out there that I also will use the IUD in those looking to, again, for bleeding control who are not looking to get pregnant. I will combine hysteroscopy, resect the portion in the endometrium, ablate the portion beyond the endometrium or any other fibroids, and then place a Mirena. So I will combine all modalities to offer patients best results. And I do think that the combination of modalities, at least for patient satisfaction, really does, patients report that they're much happier as far as that bleeding profile goes post-procedure.
Thank you, Dr. Shirazian. Dr. Hansen-Lindner, any other thoughts there?
I would completely agree. Combining modalities for sure. I probably only have 10 or 15% of patients that I do only a Sonata and nothing else. I also hysteroscope every patient because ultrasounds and even SISs don't tell you everything, but direct visualization of the cavity is incredibly important for developing the surgical plan on the day of the surgery. I don't use as many of the patients for GnRH antagonist, mainly because we have just had a really difficult time getting insurance coverage. But I do have had better success this last year and have patients who have 2-3 months or longer wait times to be able to have surgery. I do find that it's beneficial to get their hemoglobin up and help them to avoid infusions, etc. So I definitely have seen a role for it.
And truthfully, we've had a fair amount of experience on both sides of the Atlantic with use of GnRH analogs, as well as even Uapristal, the selective progesterone receptor modulator, which is not widely available because of side effects, but it does all those drugs do reduce fibroid volume 40 to 50% at 3 months, and that can really help get a fibroid, say a 10 centimeter fibroid, down to 8 or smaller, which is a much more reasonable range to treat with Sonata, to be honest.
Thank you all. We still have well over 70 participants with us, and I want to thank all of you for staying with us for this hour. We still have a little bit more time. There is one more question, but we want to get you even more involved. So Casey, if you could go ahead and post that first polling question of the group, and we'll see what kind of response we get back, and of course ask our panel to respond. So TFA treatment of a patient who desires future fertility, which tissue do you try to protect more from collateral ablation? And of course, there are 4 choices there. So I'd ask our audience to please go ahead and select which answer relates to your practice and your experience. And then Casey will post the results here very quickly. And whenever you're ready, Casey, to post those results, we'll go ahead and take a look. Okay, hopefully the panel can see the results.
Yep.
Thoughts on the responses, both equally, and then there's certainly a majority on the endometrium alone.
So honestly, we posed the same question 2 weeks ago at a similar webinar in Europe, and by far, endometrium was what worried gynecologists most in terms of staying away from it. No, I don't think anyone answered myometrium. So I find this interesting. This is very similar, but I am glad to see both equally. I'm having done a lot of RF ablation of fibroids, even in the early 90s when we didn't have nice devices like Sonata. And there were some reports of uterine rupture and subsequent pregnancies. I've always been very paranoid about myometrial ablation in women who may want to get pregnant. I personally am less concerned about endometrium, but I also understand some theoretical concerns about implantation failure or even abnormal placentation, although we certainly do beat up on the endometrium and myometrium quite a bit during hysteroscopic myomectomy, for example. The nice thing is, as I mentioned with Sonata, is you can tailor the ablation if you want to avoid both if you want. So there is that. I'm curious what my colleagues think.
Dr. Hansen-Lindner?
I would definitely agree with David's sentiment. I think, David, you said it best a few months ago. I've started to worry less and less about the endometrium in the sense that I think we've been overly worried about it and wanting to spare it. But when you look at the size of the needle entry and see how it affects the endometrium percentile-wise, it's probably, 1/500th of the surface area of the total endometrium. And especially with what we do with hysteroscopic resection, both with electrocautery and with just MyoSure and other devices that shave the endometrium, I've become a little less concerned about it in order to get optimal treatment.
Thank you. Go ahead, Dr. Shirazian.
Well, I was going to say it's funny because I would probably say that I worry a little less about the myometrium. And the reason is because, I think one of the reasons is that I do very large myomectomies, where I remove like 30 fibroids or, 40 fibroids. And those patients go on and get pregnant. So I figure if I can remove and reapproximate myometrium in fibroids that consume the myometrium, right? Like more than 20, and those patients are still getting pregnant and are not having, bad adverse outcomes, then, a little bit of ablation in the myometrium may not be such a big thing.
But let me ask you a question, Dr. Shirazian. Do you recommend those patients undergo elective C-section?
Yes. Yeah, I do. But we don't see, higher rates of major other, C-section. Yes, they're all having C-sections, but we don't see, placental abruptions or uterine ruptures or things like that. So I think the myometrium is probably also more, I guess my point is just the myometrium is probably also more malleable than we think.
Thank you all. Casey, let's throw one more question out, and I want to be respectful of everyone's time, but we still have almost 70 participants with us. So this will be the last question of the evening on the polling. What is the appropriate timing of conception after TFA with the Sonata system? For those that are on this call with us and of course have used Sonata, please, your response. Anytime after treatment, after 3 months, after 6 months, it depends on whether the patient wants natural conception or ART. So we'll just give a quick minute. Please go ahead and answer. And then Casey, when you're ready, we'll show the results quickly. Here come the results. There they are. Panel, what do you think? Dr. Hansen-Lindner, I want to go ahead. I'll start with you this time.
So I would say that 6 months would be my recommendation, but again, it might be a little bit more related to how close it is to the endometrium. Like I might say a type 4 to 5 fibroid would be 3 months, but one that's maybe directly adjacent to the endometrium after 6 months. And the only reason why I think this, it's not because of the numbers we've had, but it's there's a really good study that was looking at LEAP procedures and risks of miscarriage after a LEAP procedure, not a second trimester loss, but a first trimester loss. And that waiting longer, and it probably has something to do with the degree of inflammation in the tissue of the, in that case, the cervix, but in the uterus, that all of that healing, that ongoing healing and the necrosis and the sort of reconfiguration of that tissue, which is in a lot of ways very similar to what's happening with a Sonata, that there is definitely some probable advantage to waiting a little bit longer to reduce the chances of first trimester miscarriage.
Thank you. Dr. Shirazian?
The data suggests that post-myomectomy patients should wait 3 months for conception. So based on the data we do have regarding kind of larger surgery, I usually tell them 3 months. And usually most patients are eager to be pregnant. So, you know, in those who are trying, who are interested in fertility, they at least the ones I see want to be pregnant sooner. So I usually do counsel them that they should wait 3 months.
Thank you. Dr. Toub?
Yeah, so to be perfectly fair, we don't know, right? That has to be very clear from the start. We really don't know what the right answer is here. But, you know, we do know from at least, you know, the endometriosis literature that the clock is really ticking in those patients, and certainly their greatest chances of getting pregnant is within 12 months of any endometriosis surgery. This is not endometriosis, but that said, we're also doing a procedure in women that doesn't involve any incisions. So we don't have to worry about that as far as healing. So I think it's pretty clear to me, at least, and to a lot of the reproductive endocrinologists with whom I speak, that for assisted reproductive technology, you're going to want to wait at least 3 months. You want that cavity to be normal, and it's going to take at least 3 months for most of the fibroid volume reduction to occur. That's how soft tissue ablation works. But I think for natural conception, we really don't know. I mean, as I mentioned, we've had a very small number of women who've conceived about 3 months after treatment. And it's hard to really say anything meaningful about that. But there's also no incision to heal. So the question really becomes, if someone were to want to get pregnant try to get pregnant 2 days after the procedure, is there a harm? Obviously, if you don't try to get pregnant, you absolutely will not get pregnant. But at the same time, I do think there are theoretical arguments around abnormal placentation, implantation failure, et cetera, that we really don't know. I don't know that 6 months is necessarily the right answer, but there is no right answer. So I think if a physician wants patients to wait 6 months, that is their decision, and I respect that. I think there's something to be said for 3 months, certainly for assisted reproductive technology. Everything else is completely a guess. We don't really know.
Well, thank you for all of your comments. Obviously, our webinar title this evening, which was the Sonata procedure for uterine fibroids, a discussion on patient selection, fertility, and pregnancy, was certainly what we discussed this evening. So first off, Dr. Hansen-Lindner, Dr. Shirazian, Dr. Toub, thank you very much for sharing your experience, your insights, your perspective on Sonata. And I want to thank everyone else who attended with us this evening, not only for being here, but of course your engagement and the questions you asked. We really appreciate it. I hope this has been valuable for you. We'll invite you to our next Sonata Insights broadcast webinar. And again, thank you for joining us this evening. On behalf of our faculty and Gynesonics, want to wish you all a great evening. Thank you again.
Thank you all.